And just a reminder, we will send a copy of this out. I believe you've already got a copy. The demo that we have, we will be redoing after you guys watch this demo and offer up any questions. We are going to redo that demo to support any questions you may have around it and send that out to you as well. All right. I think Brandon's going to jump in right here and take over for the beginning.
Yep. Thanks, Casey. So again, thanks everybody. When we talk about the regional hub, there's more components to it than just worrying about whether or not there's a dispatch or things going on. We've taken our role, relatively seriously around wanting to make sure that we provide the best supports that we can and really be a good partner in most of this for you. So I'm going to walk through a couple of the administrative pieces that the hub has available so that you have some awareness and make sure you know who to get in touch with and who to ask for what and what resources are available to you by entering into the MOU. It's not really just about the crisis dispatch component. It's about all the levels of support that we've got to coordinate a good system of care across Region 5. So the first place I wanted to start was around clinical training and development. And look, we know this is a huge burden for agencies to bring in good clinical training, to be able to have access to those supports for your staff and to do it in a way that makes sense in a lot of people's schedules and things like that. So we wanted to make sure that you've got availability to all of the free resources that we've already got out there. So one of the things that we're going to do is the prime contacts for each one of the agencies that we have an MOU with, you'll be enrolled on our training announcement listserv for both Region 5 and for WTCSB. You'll get announcements of any upcoming in-person or virtual trainings. Our websites already have access to all the previously recorded trainings, and I've put those down there. If there's anybody that doesn't want to be added to that listserv, please just feel free to drop us an email to our R5 training email. I'll put that into the chat here in a few minutes. It's going to be a general mailbox that we've got, and I'll cover that also in some of the complaint places. But wanted to make sure that you knew that these resources are out there. There's also the links for the registration for the MCR training for our region under the virtual access. The other piece that I wanted to make sure everybody's aware of is that we do some on-demand training just as part of the services and supports that we offer to our local communities and to the region. And you can ask for those. So things like an abbreviated mental health first aid, things like trauma, ACEs, all those kinds of trainings that would be particularly helpful for your staff and for folks that you may work with. We're happy to do that and arrange some one-off type of trainings, or if you have a question about it, it might be beneficial to a whole bunch of individuals. So that prevention@wtcsb.org email will get you to Tanetta Hassel and some of her team. She's our clinical director responsible for training and development here at Western Tidewater, and we'll be able to work with you to get any training that your folks would need. So wanted to make sure we reference this, and all these are free, no cost for you and your staff to register for. You can go ahead and go to the next slide, Casey. Technical support and assistance. So look, we are not a whole bunch of IT professionals that all sit here at the regional hub. If I asked Staci to fix my computer, she would probably muck it up a little bit more than I started with. However, what we have been doing for the last several months is actually walking through all the beta testing of crisis dispatch, working closely with our partners at DVHDS and their vendor that hosts the Virginia Crisis Connect system. And we've been doing this for a little bit, and it's worked. It doesn't mean that we haven't had to walk through our own issues and make sure that we had good resolutions, but we're thankful for the support we've gotten. And we want to make sure that we can apply that lived experience to you and be your kind of peer support walking through that. So some useful information here is the emails for both the crisis services at dvhds.virginia.gov, which I would assume all of you are very familiar with because you've probably done something with them as part of this process to get invited here. And also the support for BHL, which is the host company for Virginia Crisis Connect, that customer support at ihr.com. We're asking in our region, if you've got a problem in Region 5, if you're working through some of those, please copy Casey Casey has been our kind of internal support to help us with a lot of these things and has gotten pretty good at resolving some things that come up. And he'll try to help guide through that and make sure we ask questions if something doesn't seem to get resolved. We're trying to track those task tickets and those issues that come up. We give feedback to the DBHDS staff on ways that we can improve it and eliminate those problems from happening in the future, or being able to put out some FAQs or some bulletins and say, hey, look, you probably shouldn't be using, Mozilla Firefox web browser for Virginia Crisis Connect. It's not a supported browser. We're going to use Microsoft Edge and we're going to use Google Chrome. So things like that. It also helps us to be a better partner for you. We know what we can do in training and support videos, what we can do in outreach, and the ways that we can help speak more closely with you and your staff. So we would just ask that you partner with us and include Casey on those emails, and don't hesitate to ask us when you have a problem with the platform. If you're not getting a dispatch, if you can't accept it, if there's something that's not working right, please feel free to let us know. We're happy to be that partner and work closely with the others. And now complaints. So as much as I think we are going to do everything exactly right on our end, and you'll have absolutely nothing to tell me that we did wrong, we figured we'd make up this process anyways. For the most part, because we want to make sure we preserve our primary clinical resources for any of our clients, and make sure you know who to go to if you do have a problem, because there may be one or two that come up. So the big thing I want to stress is please don't call 988 or our local or our regional line that goes to the call center, the 757-656-7755 number, to get a complaint resolved, or if there's an issue with tech support or things like that. Those are frontline staff that are specifically trained to walk through a crisis situation and do an initial triage with individuals. And we want to make sure those individuals get their phone call answered as quickly as possible. And so we do that by not tying them up with it. What we do want you to do is email us at this email address, r5hub@wtcsb.org, or by calling this phone number that we have here. Staci, whose phone does that actually ring?
Mine.
All right. I thought I asked the right person. So, Staci, as a former emergency services director and hospital discharge work and NGRIs and everything else, is used to answering her phone. We'd ask that you preserve her sanity just a hair bit. And, if it can wait until 9 o'clock the next morning, then that would be great, instead of calling her at 2 a.m. But if there's something that really needs handled at 2 a.m., we know how to answer our phones. But that email address is a really good one also to document, whatever the problem might be, and can get you probably the fastest response, because there's a few of us that are on that email address that will be answering and responding to those questions. If we don't resolve it in step one, which I think would probably be a pretty rare case, we would ask that you submit a formal written concern to Staci and copy both Demetrios and myself, and we'll be handling any of those resolutions through a written response within 5 days. That's our commitment to you, is that we're going to provide you a written response to that concern within 5 days, probably quicker than that, but things that require more thinking and planning, we may even reach out to you and try to have a discussion at that point. But that's the first formal step. And then if we don't make a resolution there, we would ask that you reach out to us again and include DBHDS in that one. And DBHDS can assist us with being some of the moderation of what might be coming up as a problem. And we would have a meeting held within 10 business days, and we would have a formal resolution provided out to you within 20 days. And so those would be for things that are not more easily resolved, maybe a business practice question, maybe something else that's going on that doesn't seem correct to you. So we're happy to walk through those processes, and just want to make sure everybody's aware of this. And we wanted to throw it on this slide so that as you guys have a copy of this PowerPoint, you're able to you're able to reference it and see it, and it lives on in perpetuity, I guess. So those are some major administrative kind of tidying up points. I did want to just ask if there's anybody that has any questions around those things before we would dive into some of the more practical training around what does mobile dispatch look like and all of that. So any questions out there, please feel free to just raise your hand and we'll get you called on. I do understand that we hit our Zoom limit on the Zoom account we used to host this, so there might be some staff that didn't get in because we hit 100. which was more than than we were expecting. So we will make sure we get the link out to the recording of this training. And if we need to, we can get a second follow-up session scheduled here in the next week or so before the dispatch goes live. Hopefully we've gotten most folks in, but we'll be doing some follow-up with others. All right. I see a hand from Demetrios.
Yeah, I just want to again reiterate the importance of our business relationship. This process has got a lot of moving parts, and we hope it's just the beginning of a lot more collaboration and work that we can do to really strengthen the crisis network across the Commonwealth. To that commitment, my expectation is that if there's a concern or an issue, we work through it. Business partners do that. I think that's the basis for a level of trust and commitment to being able to work through the processes. So you have my personal assurance as the executive director of Western Tidewater that I will commit to helping to resolve whatever issues or concerns that there are to everybody's mutual satisfaction. And if not, then we'll bring Kurt in and some of the big guns from the State Department and help us walk through whatever we need to walk through so that we can own what we need to own and have a more productive relationship.
Yeah, I just want to jump in real quick. I mean, thanks, Demetrios. I don't know if big gun is the right adjective, but I just want to second that the premise and what Demetrios is saying. You know, and many of you probably were on the statewide webinar we had a few weeks ago. And I said there that this step is, we recognize the significance of it. And I just want to reiterate the why. I've said, and we've attended meetings for, well, I guess Region 1 still upcoming, but across all the regions, similar meetings to this. And I take pains to always go back to the why, at least the why from my seat and from DBHTS, which is to evolve the system to get closer, ever closer to the SAMHSA best practice. And that, well, I'll speak for myself, but for the department is with the intention to help all of you, all the providers, be able to serve people better. But as Demetrios says, change is complicated and it has impacts, and sometimes there's disagreements. So I appreciate what Demetrios just said and what's being set up here, and we follow straight behind. This change isn't to pick winners or losers or cut people out or make the system work for some and not for others. It's to really evolve us to a better statewide integrated system. But we understand that's hard, and so we want to be a willing partner to help it work for everyone the way it needs to, so that people are served well.
All right, we're going to move along. So we're going to get into the meat and potatoes of this meeting here, which is our workflow, our dispatch procedures, and some training for you guys on how we operate. So this is a reminder that I know some companies out there that are going to be here may operate in 2 or more different regions, but this is going to be specifically how we handle things here in Region 5. And we do the things the way we do them for several important reasons. One, we want to make sure that we give the best possible care to all of our clients in our region, right? And second, we want to make sure that our clients, as well as our mobile responders, are as safe as possible when going through these processes. So some quick definitions that we're going to use. So if you see RC5, that's going to be Region 5 Crisis Call Center or Crisis Network. CSB is our Community Services Board. BHA, Behavioral Health Authority. NSPL refers to our National Suicide Prevention Line. We have 2 vendors that currently answer those lines for us in Virginia. That's going to be Hope Link and Frontier. PSAP, or Public Access Point, or 911. Those are your 911 vendors. MCRTs are going to be our Marcus Mobile Co-Response Teams. So we have a couple in Region 5. We have Virginia Beach, who has a Marcus mobile co-response team, which is law enforcement and clinician. And Hampton, we have law enforcement first, then clinician to show up for their Marcus team. Newport News utilizes their CARES team, which is the EMT and a clinician to respond. And up next is Suffolk. Suffolk's going to have a paramedic and a clinician to respond for their Marcus team. That will be by July 1, 2024. So ES for emergency services. Those are our clinicians that we call that have to do our ECOs and TDOs. LE for law enforcement, ID for intellectual disability, DD for developmental disability. We use DX for diagnosis, EMT for emergency medical technician. CIT would be a crisis intervention team or crisis intervention trained officer. So as we move forward, we're going to go through and show you the points of access, information that's going to be needed for a dispatch to occur, what to expect from a dispatch, and safety. So here are our current points of access. We have 911. So we have 9 PSAPs or 911 centers in Region 5 that currently transfer calls to 988 for us. Our consumers can dial 911 in those areas and be transferred to 988 if they're level 1 or 2. So if they dial 988 on their own, 988 is not geo-located or geo-routed. So what that means is they get routed based off of their area code. It's not like 911. So they're going to be routed back to wherever their area code is from. So a good example of that is Brandon. He has an area code from Pennsylvania. So if he dials 988, it goes back to Pennsylvania. He does not get Virginia's 988. There are over 200 vendors national for 988. So just to remember that. So that is why we've come up with our community line, which we tend to give out as much as we can. If you dial 757-656-7755, you will still get 988 vendors, but you will get our 988 vendors for our region every time.
And that's a line, just real quick, that please give out to the people you serve as part of your crisis planning and those types of things, especially if they don't have that area code that's localized. That vendor knows of all of our services and how to request a dispatch. So feel free to please give out that local line as well as the 988 number to the folks that you serve.
So next, we're going to go over information needed for a dispatch to occur, right? Before we can send you out, we're going to collect a level of information to where we feel comfortable to be able to send you out safely. We're going to go over that in the next few slides. One of the first things we'll collect is the PSAP CAD number, if they have it. And the reason we collect that is if we have to refer back to our PSAP, it's much easier for them to enter that CAD number and pull up the case they've already started versus trying to look over someone's name or look up an address or something like that. Or a phone number. If you get 1 digit wrong, it'll throw it off. So we'll have that CAD number from them. A credible number or other type of document number, if we have it. The consumer's name, consumer's phone number, and the consumer's current location. If they're located in an apartment, hotel, hospital, we also collect a room number, unit number, things like that. We get an age and a date of birth, and a brief description of the presenting issue. What is the reason for our dispatch? Consent for dispatch, and any type of volatility or demeanor. So basically, what's going on with this consumer? Why are they requesting a mobile response? Could be something as far as schizophrenia, could be they're having some issues with their meds, could be suicidal, want someone to talk to, could be a brief number of things. And then the next thing we collect are any other diagnoses that we have, especially unique ones like ID or DD, so intellectual disabilities and developmental disabilities. And the reason we collect these and stand these out is because that requires a special team. So those require our reach team to respond. So we have to get those to our reach team.
And Casey, just, for everybody's edification, you're not responsible for having all of this information to accept a dispatch. This is information we're collecting on the front end. And some of the reason we wanted to walk it through with you is because, existing clients may ask questions like, what do I need to know when I call, or what kind of questions will I be asking? We want to just make sure that you guys have some awareness of some of the basic information that's collected at the front door. And that way you'll also know what's going to be available in their record, as well as what folks can expect. We also have found sometimes individuals require some assistance while they're calling. So there may be, some questions from your staff that, how do I assist a person with making some of the phone calls, or what are they going to ask? And just wanted to make sure we had some of that information laid out here for your review. Sorry, Casey, just wanted to give some context.
No, thank you. Yeah.
Hold on one second as well. And your date of birth and your age, if someone doesn't have an exact date of birth, that's okay, but we do need to know if it's an adult or a child, again, because of specialized teams and responses. So if someone in a crisis, you may not be able to have it, or someone's calling on behalf of someone that may not have that exact date of birth, but we would need to know if it's an adult versus a child due to the team responding.
And so if we get a call and it comes through a third-party caller, which happens from time to time, we like to notate for you guys responding, are we talking to the parent or guardian? Is it a responsible assisting adult, or a facility? We get the name of the caller's number, and the caller's location. If it's a facility, we also like to collect name of staff member that's going to assist us. And the reason is we found that a lot of these facilities that you respond to, it's hard to utilize our check-in system. So we're going to want to be able to call somebody to make sure that you're okay for safety. That's why we like to collect that information. This information is imperative that we gather for the dispatcher or clinicians when we contact is made during our responses. Safety information that we collect. Is there any current substance use? If they have COVID in the home or will be wearing a mask? Is there any injuries current? If the scene is safe, scene safety issues such as known weapons, animals or other people in the house, physical aggression or violence. We don't want you to show up to a scene and not know that, hey, he's got a uncle in the back that lives in the back room, and they just come out on you. So we want to make sure you're aware of anything that could possibly go off in the house. And if there has been any physical aggression or violence, if there's been recent physical violence, we're probably going to ask for a co-response, and we're going to send out law enforcement first. We try to collect if there's been prior law enforcement involvement and how that ended. The reason is maybe somebody just got put under an emergency custody order recently, and they're not particularly fond of law enforcement. If I need to call law enforcement out to support you, I want to give law enforcement that information so that they know what to prepare for when they get on scene, so that they can keep you as safe as possible. So we're going to talk about our levels and how our levels come in for triage. If we have a level 1, this is handled by 988. So this does not come to a dispatch. Level 1s are handled on the phone, and we don't need to dispatch out anyone for mobile response. Level 2 is our meat and potatoes. Is a consumer is willing to see someone. They have a combination of SI, suicidal intent, homicidal intent, maybe a means or a plan, but not all three typically. They're willing to see a mobile team and or participate in a safety plan. They could have a loaded firearm, but it's in another room with no intent to use it. We have a lot of homes, especially here in our rural area, where we have hunters, right? So if you ask them, hey, do you have a firearm in the house? They're going to say yes, they have a firearm in the house because they have shotguns, rifles for hunting. That doesn't mean that that's their intent to use that. So we ask further questions to clarify that. So our level 3s are our co-response typically. So it's going to be typically where we're going to ask a mobile responder to go out, but there may already be a first responder on scene. Someone maybe have been actively cutting themselves. So EMT shows up just to make sure that there's no issues going on. Maybe they say they took a handful of pills. Not sure what that is. So we're going to make sure EMT checks them out first. EMT may say, okay, well, they took 3 Tylenol. So they don't need us, but they do need someone else. So that's when we're going to get a mobile clinician out there to talk to them. Typically, law enforcement will be asked to provide scene safety during these calls. And then our level 4s, which are law enforcement first, always. They have a loaded gun. It's in the room. They're ready to use it. They're not going to make it safe. They've taken 15 to 30 pills. They have a plan, intent, means, or they're currently under an ECO or TDO. So this is where we get a lot of the clients already been put under an ECO, emergency custody order, and they've gone through the process with emergency services. And now emergency services is thinking that they can possibly release them instead of a TDO, and they're looking to utilize a mobile team as part of that safety plan. So this is where you might get a level 4, where someone is currently in a hospital under ECO, but they're looking to utilize a mobile clinician or mobile responders to help facilitate a safety plan to divert that person from TDO.
Before you go on, I want to acknowledge a couple of things in the chat, Casey, because I'm helping monitor that. The first was a statement around they do have to consent to a dispatch. So yes, anybody, if you're going to someone's home or anything like that, they absolutely have to consent to a dispatch. If it is a facility, for example, maybe a school or some other sort of entity like that, where there's either a pre-existing contract or some sort of arrangement where the facility can request a mobile team to come in and maybe support existing staff, then it isn't necessarily that that individual has to have the consent, but the facility is the implied consent in that particular moment as a resource for them. So I wanted to give a little bit of a clarification on that statement in there. And then I also wanted to say, we're giving you a huge amount of information right now. We are going to be doing some supplemental trainings on the crisis continuum, how to access different points in the crisis continuum, and how to utilize those resources to include how you step people up to care, how people kind of get stepped down to care, because Casey was just talking about maybe, a step down from a emergency custody order. So I want to rest assured of some folks, because some folks are chatting around that we will be doing some more additional training this meeting, and we'll be having ongoing training series, ongoing support series. So feel free to put those questions in the chat. We'll try to get out some FAQs to you all. But I just wanted to re-emphasize that we're giving you a quick overview, and we'll be providing some more additional resources and training on those intersections. That's all I have in the chat for the moment, Casey.
So what to expect from a dispatch? The dispatch process involves information put in from an SPL, typically a call agent from the SPL, into the data platform or VCC, and then updating the SPL on our workflow process and coordinating with our mobile teams for crisis response. If the mobile responder team does not respond to the dispatch, if a mobile team doesn't respond to the dispatch, attempts to engage in alternative teams, escalating to central and remaining hubs if necessary. So what that means is if someone doesn't answer when we go to dispatch them, we may have to escalate that to another responder, or it may have to go to one of our regional teams to respond out.
Casey, just so folks know, the regional teams are sort of the public mental health backup system, just like emergency services is for the ECO TDO system when someone might need a hospitalization. If for some reason we can't get any of our teams to accept a dispatch out, or the distance again is too far, they are sort of, again, a safety net mechanism, and that's why you see it referred back to in that particular case.
Once a mobile team is dispatched, communication with the PSAP and emergency service is established by our dispatchers. And then our check-ins are performed once a mobile team member is on scene. So once you say, yep, we're taking this case and we're en route, my dispatchers are going to start calling the PSAP for that area and let them know that you're headed to a call in that area. And they're going to call emergency services just to make sure that they don't have any information that you guys might need for continuity of care. And then when you leave that scene, they're also going to call them back to let them know that that scene is clear. Check-in is typically done, and we'll go over this in a little bit, but just to give you a heads up, once you arrive on scene, you've marked arrive, we wait 15 minutes, and then we're going to call you on your phone just to make sure we can get a good listening to what's going on in the background and make sure you're safe. After that check-in, the check-in is on you to hit your check-in button in the VCC. That takes every 15 minutes. If you don't hit it, you will get an alert saying you have to notify dispatch. If 20 minutes pass and you have not hit that button, the dispatchers will get an alert saying that you have not checked in. They will check in on you via phone. If you do not answer, they're going to call for an immediate welfare check from law enforcement. Have them come check on you. Additional resources can be requested during an active call with coordination with dispatch or mobile teams or other resources. There's a chat involved, and you can always ask for any type of other resources you may need through that chat. Case completion is followed by placement in the RC5 Navigators team feeds for follow-up. So when you're done with your case, we will take and add these cases to our Navigators feed, and they will make sure to follow up with the clients to make sure that they are getting with any type of plan that you've helped them set up.
Hold on one second, Case.
Yep.
So Care Navigation, for those of you who may not know, that is a regional resource that we have that does a couple different functions. One, it can provide some ongoing and linkages to additional resources such as a food bank or some other things that might be also very useful in a crisis. Or even if there's a private provider, they might be able to advocate for, hey, this person came up and they need an earlier appointment with your agency and those types of things. The other important function that Care Navigation does is a level of quality assurance as well for each of the kind of calls that we go out on. So that's why you'll see that they get circled into all the calls that we do. So that way we can provide any additional feedback. I'm a big thing of catch me being good. So if there's some great things that we hear, we want to be able to pass that along to you as an agency. If there's some area for improvement, or it's also another great way to identify ongoing training needs that we might need as a collective whole, to say, hey, we keep getting this sort of feedback, so maybe we need to organize a training or some sort of resource to address something. So there's a couple different functions that Care Navigation operates, and they operate under us as the regional hub as well. So just wanted to provide a little clarification about their role.
Did we just go over that level? If level one case for Care Navigation? So a level one, if we get level one cases for Care Navigation, they will be placed in the Navigators feed. Also, we have reach follow-up feed for level ones as well. But typically they don't come through our VCC right now. They will be, they get sent to us via Teams, and we hand those over to our two teams.
So I wanted to emphasize that when we start going through the chat feature, when you guys receive a mobile dispatch, so let's say, for example, you guys go out and you're working with a family. And like I said, a prime example is maybe that food bank, right? And you would like to connect them to Care Navigation. You can make that request in the chat to our dispatcher, because right now the VCC doesn't have the direct way to refer, but eventually should. And that way we can also assist that particular person. So if you have someone that you're seeing in crisis as part of your mobile response, and you think Care Navigation obviously is a good follow-up, you can request that. We tend to do it across the board, but we want to make sure you know that if you're talking to someone or anything like that, we're happy to assist in some of those referrals.
So to get back onto safety, like we talked about before, so welfare checks are performed by dispatchers with mobile crisis responders, including the phone call within the first 15 minutes of arrival, and then check-ins are required every 15 minutes after that via the VCC data platform. It's a little, if you're not familiar with it, there's a little button at the top that says check-in. If a mobile co-responder or mobile crisis responder misses a check-in, at 20-minute mark, the dispatcher will be notified. So they are going to be calling that mobile crisis team, or mobile crisis responder, to get a check-in. If not, then we are going to be calling the PSAP and have them do a welfare check. Additionally, when you need any type of additional resources during an active call, the dispatch will coordinate that with PSAP and request any various teams prioritizing a CIT trained officer respond over a normal officer. So also, there is a button in there, an SOS button that you can hit that will immediately call law enforcement for you. It will skip everything. So if something happens and you have to hit that, that will also get law enforcement coming to your location.
So I want to follow up a little bit to give you a couple additional details. So when you guys accept a mobile dispatch, one of the things that we do behind the scenes is we call that local 911 center, also known as a PSAP, to let them know that a mobile team is going to be at a certain address and location. That's that CAD number that Casey kind of referenced as well. Is we get the number for them, and we might say, for example, Casey's going and Demetrios are going to 123 Sesame Street for someone who's experiencing suicide ideation. We don't give the person's name or anything that identifies that person at that particular moment, because some of our folks have outstanding business with our law enforcement partners, and just to protect their privacy, right? So, but we do want to let that 911 center know that we have a mobile team at this particular address, just in case you hit that SOS button or in case you need to request additional services. The other thing we're doing is also calling emergency services of the locality you're responding to see if there's any active pre-screenings or crisis that has been done by a local emergency services board, because that's, again, important information for you to know to coordinate that call around safety. Then we will let the PSAP know when you arrive. We will also let that 911 center know when you leave and if there's any disposition. And of course, as Casey just alluded to, if you need help, we will ask for that type of assistance. So I want to let you know, we do a lot of things behind the scenes to try to make sure that your safety is well monitored and looked out for and coordinated. So this is something we've been doing ongoing. It works very well. We've built a lot of relationships with our 911 centers so that they know that we're calling from 988. And because your safety is probably the #1 priority of our dispatchers when you're out on scene. A lot of our dispatchers came from the 911 world, just so you know, so they're very familiar with that kind of system of care, and want to do what we can to make sure that when you're out responding, you have all the appropriate resources as much as possible at your fingertips, especially as it relates to safety. Thanks, Casey.
So mobile responder side, how and when to check into the VCC. This is very important for you guys, as I'm assuming you guys are going to be trainers. Make sure that you can check on your people's locations, okay? If they are going through, and you'll see in our demo, if they're going through a VPN or a mobile hotspot, it's probably going to show them several hours away. The other day when I was logged in as a mobile responder through my mobile hotspot, it showed me in Texas. So I would clearly never give a dispatch because I'm not going to be close. So you need to be able to check where your location's set up and when you're logged in. So the information that the dispatchers are going to need from each provider, we need to make sure that all their phone numbers are current and in their profile in the VCC. And again, you'll see where that is in the demo. Their responder credentials. If you do not have your credentials put into the right place when they go to dispatch you, they're not going to be able to know who you respond to, so you're not going to get a dispatch. They don't know if you are adult, child, or both. So make sure you put your credentials in. And again, you'll see that in the demo. If you need to verify your roles, agency leads should be confirming that their staff have the appropriate roles within VCC in order to receive a mobile dispatch. If you're not set up as a mobile responder, you may not be able to get a dispatch. You may just be in there as a crisis call taker. It may look different. So you've got to make sure everyone has the proper roles in order to move forward.
And it's important that you guys check that, because we may not have access to all of your staff in their roles. So that is something we can't always, as much as we want to be helpful, we can't always be as helpful. We might be able to give you some guidance around what role to look for, but to just make sure that you check your own staff. While you're getting the demo set up, Casey, there was a couple questions in the chat around community crisis stab, and I think Brandon answered that one. If a consumer is only at level 1 and a safety plan is created, can they be referred to the community stabilization for additional support? Yes, those cases can be referred to community stab in accordance with the avenue that DMAS is highlighted. So I wanted to make sure that you knew that. And we asked about if additional staff need training. This goal was to have a train the trainer sort of model. So people were supposed to be sending folks to this particular training to get some of that train the trainer. However, this is being recorded. We will be sending out another demo to incorporate any questions that might also come in as part of this training that might assist, that you can use in future presentations with your staff and ongoing as well. And then if that doesn't suffice, then of course we're going to try to help you, as well as the VCC is offering, also known as BHL, or also known as the data platform for a lot of us, is also offering some learning sessions around some of the technical nuances and things like that in procedural stuff as well. And there are some training modules also located on their data platform. Brandon, did you have something to add? I saw you come off mute.
Yeah, I was just gonna, also say, that I'm not sure if the question was around actual MCR training itself versus training on the platform, and just that, of course, we're dispatching out staff that are qualified as having that training per the requirements from DMAS as well. So just making sure that we have qualified staff to be dispatched out. And before we jump into the demo, I just want to make sure I'm not certain that Kurt's going to be able to be with us the whole session. And so just out of deference to his time and all of that, I wanted to open the door and just see if he had anything that he wanted to jump in and add before we jumped into the actual demo part. Kurt, are you still with us?
Yeah, I'm here. I appreciate that. I'm gonna hang out, but I'm happy to talk now. And then I've seen the demo a few times, but it's good to watch, so I'll watch it. And forgive me if I'm sending emails on the other screen at the same time. But yeah, just two things. First, just grateful to all the folks at Region 5 and to everyone that's joined the call. But this is great, and it mirrors conversations that have happened in other regions. Every region's a little bit different, but it's pretty neat and affirming to kind of watch from my vantage and see some systems start to be developed at a statewide level. And so I'm just grateful. It's a lot of work on everyone's part to pull these things together. And we'll see how it goes on the 15th and 16th and January 1st and February 1st. And this is not a one-time thing. It's an evolution, right? So we do this change and we track and we monitor and we track and we monitor and we continue to evolve the systems. But just a lot of gratitude for all the folks in Western Tidewater and for everyone else that's joined, that's going to go on this journey with us. The other thing it's kind of a sidestep, but I think it's important context. I don't know if folks had the opportunity to log into the webinar last week that Commissioner Smith and Director Roberts did. But I think there's some content there that's important context. That's one of the questions in the chat regarding community-based STABE. And I've realized over the last month or two, as we've been sort of moving through this process, that we haven't done, and we meaning the state, I'll lump DMAS into that, they can speak for themselves, but we haven't done a good job really defining what mobile crisis response is, what community-based STABE is, how they're similar, how they're different, and the other services that are mobile and deal with crisis, like ES or REACH for that matter. There's a lot of different services that move around in the community and serve individuals in crisis. And when I say we haven't done a good job, that's no slight to any of my colleagues or predecessors. It's just this stuff is complex, but it's going to serve us well to better define these services and how they fit and how they work together. And the question in the chat is a really good one. There are mobile crisis response is a rapid response to like an EMT, right? And in my mind, they're the ones that get there quickly, put a wet Band-Aid to make sure the person can make it through, and then connect them to the next necessary service to help move through the crisis experience, mitigate the risk, connect to services, and reduce the risk of future crises. So that we need to remove provider choice, not because we don't want the person to have a choice, but because we want to be able to move quickly and swiftly and get resources there immediately, right? That to me differs than the role of community-based aid, right? Which is what I know Commissioner Smith and Director Roberts talked a little bit about. Community-based aid has, I see, a tremendous amount of utility for folks that don't need an immediate rapid response, right? That aren't in such acute crisis or acute risk that you need to get someone there that moment, but do have that would benefit from ongoing support and service, connection to resources, treatment planning, bringing in natural supports, helping those people acclimate to what the individual might need to further stabilize. It's a much more complex service, right? And so we need to, one, define these things, how they're similar, how they're different, both from a DVHDS perspective around service delivery, service definition, licensing, and from a DMAS perspective. And I won't speak for them, but we need to have an ongoing conversation around how these services are supported, both mobile crisis response and community-based aid, and how they connect. The question in the chat was, and Brandon and Staci's response was spot on. I was halfway towards typing out a similar one myself, but I think there might be a discussion to be had in the coming year around, is there utility in the call center being able to be a referral for community-based aid if mobile crisis isn't indicated? That's not currently on the list of referral sources in the DMAS manual, but maybe it is in the future. And that's a conversation we should have, and is better had when we really understand how we apply mobile crisis response and how we apply a community-based aid, and how we can ensure that the right service gets to the right person, right help right now. So I just, it's been a learning process for all of us, and then a pledge to all of you that we will do better to clearly define the different services in the crisis continuum, how they're connected, and to make sure that the providers of the various services are supported so they can serve people well. So don't need to belabor that here, but I think I find myself bringing up in just about every meeting, because I think it's important to say and to have that context in the background. I would say I'm happy to take questions, but I think that maybe this isn't the forum for it. But if there are questions for me or for DVHDS or for DMAS, drop them in the chat or send them to us at the crisis_services email. We're updating the FAQ document. We sent out an initial version after the first statewide webinar, but we've been collecting additional questions, and there were some that we just weren't able to respond to due to the short time before the Thanksgiving break. So we'll be releasing an expanded version of that FAQ. We're hoping by the end of the week, but there's about 40 additional questions on that sheet. So end of this week, beginning of next week, we'll get more FAQs out. So if there are more questions that haven't been answered, please get them to us, and we will include it in that FAQ document and in ongoing conversations.
I want to follow up on one thing you said, Kurt, and because it's a nuance. So the hub can't necessarily mitigate your billing questions. Like, we're not your billing source. However, if there is a question around the MOU, like I worked with a couple companies recently where they had some nuances around the MOU and wanted some clarification to push through the billing, then that is absolutely something to send to our regional email. I talked to an insurance company yesterday. We got it resolved and we're working on it right away. So if there's a nuance around that particular part of your billing, like maybe the insurance company wants to talk to the hub to ask a couple clarifying questions or those types of things, happy to help with that. If you actually have a particular nuance with the actual billing around the rate and DMAS, Unfortunately, I can't be your go-between between that, but so you would need to direct it that way, because I know sometimes it can get really confusing. I've had a few people call us and ask us about some billing questions, and I've unfortunately had to say, I can't advise you on whether or not this will get paid or that won't get paid. Those questions have to go to DMAS, but if there's an MOU related question, absolutely willing and happy to help with those particular pieces and parts.
While Kurt was giving some really excellent points, I answered a whole bunch of questions in the chat that I will refer you to. Go ahead and read on your own as you're able to do so. I think after this, we'll try to go ahead and summarize some of the questions. We'll try to cut and paste some of that out of the chat and just go ahead and put that up with this recording so that you guys can see those and have access to those. But just wanted to refer you to some of the answers that have already been put there in the chat. And we'll continue to reply to those messages over there. So keep an eye out on those. And if you have anything, feel free to jump in. So Kurt, really appreciate that explanation and just kind of some of the work that's been done with DBHDS and DMAS to try to get us all into a place where we can be comfortable. Are we in a good place to move into demonstration from Casey?
I'm ready if you guys are.
I think so, because we can answer the other questions at the end. And the demo might help answer some of those questions.
Okay, so just for reference, this is going to be a dispatch where Shelly is a dispatcher. So you'll be seeing her dispatch dashboard, and she'll be dispatching out me as Western Tidewater Mobile Team 1. This will take about 14 minutes to view. Good afternoon. This is going to be a demo of Region 5's mobile responder receiving a dispatch.
Is anyone else having trouble hearing?
Yeah, I don't have any audio.
I don't hear not one thing from.
Yeah, I don't hear it
I don't
either.
hear anything.
Casey, when you share, is this a video recording?
Yes.
When you share that, you have to share it differently. On the share screen, you have to choose. There's a little button that says to share audio as well. So we probably need to go ahead and restart this.
We're all learning. Thank you guys for your patience.
Should be a checkbox at the bottom when you're choosing the screen that you're sharing. There should be a checkbox that says share audio as well. It's actually share sound, sorry.
Good afternoon. This is going to be a demo of Region 5's mobile responder receiving a dispatch. You are currently looking at a dispatcher dashboard. We have had a case come over. It's going to be for free dispatch. So the dispatcher is going to hit the dispatch button, which is going to bring up the client's location. She is then going to find the closest mobile responder. You can see I'm here at the bottom. Western Tidewater Mobile Team 1 says I'm 21 hours away because I'm going through a mobile route or a mobile hotspot. So I believe it shows me up in New Jersey. Also, you can see I don't have credentials in place. So if I don't have credentials, I'm not going to be dispatched. We can't dispatch out anyone that doesn't show credentials. So we are going to show you how to input that now. I'm going to show you the responder screen now. All right, so this is currently what it would look like while you're waiting either on your phone or your computer to receive a dispatch. If you go up here, once you put all your credentials in and everything, you're going to be sitting here waiting for a dispatch for us to give you a dispatch. So I can my profile, it'll populate, you can change your name, make sure your phone numbers are in. And down here for credentials, you need to put if you respond to adults or children, or both. You also want to click this box right here so that you only receive mobile dispatches from your region. Otherwise, you're going to get notifications from every region. Click save. We're going to go back to Shelly's going to show you what that looks like now. You'll click on dispatch again. And you'll see, of course, my credentials are in play now. You won't have to do that every time. You just have to do it once, but we need to be able to see it to be able to dispatch you. If she clicks on my number 2 where it's at, click on number 2 over to the left. Don't dispatch yet. Cancel that. It should take her on the maps where I'm at. It did. So apparently I'm in Austin, Texas right now. If you click on number 1, it'll go to where number 1 is. Whoever that person is, they are in Lynchburg right now. So I'm going to go, before she dispatches me, I'm going to go back to my screen so you can see what that looks like. And then we'll tell her to dispatch. Okay, she has dispatched me. So it pops up just like this. You'll see the name, provider test, case code, if there's a primary or secondary concern, language, adult child, where their location is, what type of location they're in, the level they're dispatched at, the region they're in, the county, the phone number. If there's any guardian information added to it, it'll be here in this dropdown. If there's a representative added, it'll be in that one. If there's any transport information, it'll be in that. You can reject or accept. If you need more information, we go up here and we look at the caller info. So I'm going to click on caller info. This is going to show us when the last time the case was, updated. Again, there's a name, there's a date of birth, age, their phone number. We don't have any representative information, or it would be there. Here are some notes that we can look at. So we can see here, There's no PSAP or CAD information. There's no credible number associated yet. We don't have a third party representative calling in. We have the caller's name, phone number. If it was at a facility, we would have extra information here for you. We don't have anything for the consent to dispatch or presenting issue. We do have that they have autism spectrum disorder in here, so this is typically going to be a reach call. So then substance abuse is none, COVID none, no injuries, weapons in the home is none, no animals in the home, no physical aggression or violence, no other prior law enforcement involvement, and it is a level 2. If there was any special instructions, it would be here. If there are any special safety notes, they would be here, and you would get those. So now that you have those, you should also receive a notification of a chat by case. You are not going to know which dispatcher sent you this case, but this our dispatchers know who they sent it to. So for you to be able to converse with them, they should be sending you a chat request. I'm going to go back to the board, and I'm going to wait for Shelly to send me a dispatch chat request. If at any time you need help, you can hit this, and this will send our dispatchers an alert saying that you need help, and they will get help to you. Shelly, if you could just send me a chat that says test or something. Up here, you'll also notice that I'm in a dispatch is my current status. You can change that from time to time. If you are anything other than available, we will not see you on the dispatch request board. All right, so I just got a new message from Shelly. You'll see that it popped up here on my message side, and it should also go over here in my chat box. So I can go here, and I can see this is me. This is the case. All your cases will be on this side. Here's her test. I can respond back. Thank you. So this is the start of our two-way chat. So if you have any other questions for the dispatcher, you can get that answered here. What is that? And then for that, I'll just go back here to mobile team member. And now I'm back here. So let's show Shelly's screen real quick again. You're going to see that I have not accepted this yet. I'm still reviewing it. But I have she's reached out to me, and I've acknowledged that I'm reviewing it. So now we're just waiting for someone to accept. So what that looks like for Shelly, we'll show you. Go ahead, Shelly. All right. You can see it's now grayed out over here, saying that it's been dispatched. If she goes into the details, she'll be able to scroll down to the bottom and see that I was dispatched. If something happens and I get stuck in traffic after I receive it or something, I can reach out to the dispatcher and they can cancel me off of it and find another mobile team member to respond. All right, so we'll go back to me, and then I'll show you what it looks like to accept it. All right, so we're back on our mobile responder screen. Again, if you need to review any info, you can go to caller info right here. Then once I've accepted it, I will say, yep, I'm going to accept it, and I'm in transit. So that changed my status. That brought the information up here to the front. And now that's going to go over to Shelly, and she's going to see that I'm in transit. It's going to show that that just changed a few seconds ago. It also updates it on her end. So this is where we're at, marked that we've arrived on scene. So now I'm driving to the location. I've just arrived at the location. I'm outside. So what I'm going to do now is I can chat with my dispatcher. I can say, hey, click the chat button, click on the case, mark, say, I have arrived. So they get that. I'll also change it. But this also sets another timer for us because we're going to call you once you go in and meet with the client and you've been with them for 15 minutes for your safety. So then I go back to my mobile team member. I say, I go here to back. I scroll down and mark arrived. I successfully changed my status to arrived. At any time, if something happens, you can hit the SOS button. But every 15 minutes, you should be hitting this check-in button. This let us know that you're okay. If you do not hit this button, we do not know if you're okay. At the 20-minute mark, we get an alert up here to tell us to check on you. If we go to check on you and you do not respond, we are sending law enforcement to your address immediately. Again, you can chat by case here. You can download the assessment here. You can start the assessment and go on. So for the purposes here, you will refer back to how your policy and procedures dictate you do your assessments, but you will do it your way. But when you're done, you can click back, go down, assessment started, or if you can't start an assessment, if it becomes an ECO or something else where you can't assess, then you would mark unable to assess. If you can, you start the assessment, complete per your policy and guidelines. Then you can go back, go down to complete assessment. Shelly sent me a message saying she's going to make voice contact in 15 minutes. Of course, we're going a lot faster than one of your contacts will actually happen. So we're sitting here, we're done our assessment, going to go back, and now we complete the case. And we put our disposition outcome. You can type in your outcome, I believe. It's not letting me do it. This may be a future because it's not letting me type in here. We answer these questions typically as well, but right now there's no drop down and nothing we can do with that, so we're just gonna hit save. And now we're back and we're waiting for another dispatch. Now, if I need to reset back to wherever I was, what I can do is I can take myself from available and mark travel time or documentation time or not available. But anything other than available, and you will not be seen for dispatch. So just remember that. Now, thank you for watching this demo, and please direct any questions you have towards our staff.
Thanks, Casey. So a couple of questions I want to hit in the chat and address kind of just out loud because I think they're important ones from during that video. First, I didn't get a chance to type a response to this one for Sherry, but it appears to be based on a one-person responder. That's correct. We're going to dispatch out a singular responder through Virginia Crisis Connect. And if you would like to add a second person to that team, you can do so and in accordance with your own protocols within your agency. So we're only going to identify the closest responder, dispatch them, and if there's a second person on that team, you as an agency can direct those to respond together, but it'll just be the closest one that is identified to go. One of the other questions that came up was—
Brandon. Just for you, but if that person appears as available on the screen, please let us know that that person will be accompanying your responder and mark unavailable so that we know that person's, otherwise you might get another dispatch.
Or we could actually dispatch out more than one responder. So in the chat, if you say Shelly's going with me, then we can dispatch Shelly to that case as well. They'll both be in the dispatch. They'll both be able to hit the check-in button. So not both of you have to do it. Only one of you would have to do it, and it would update the dispatcher.
Casey, can you make sure that we drop that when we do FAQs, that we add that as an extra point and include that in the next demo? Thank you. There was questions about what do my staff need to download to be available. So I want to walk through that just kind of as in general, but I do really want to encourage folks to use the training on the platform itself, as well as to get into some of those office hour type of sessions. Number one, there's the application right now is completely browser based, which means that you run it on Google Chrome, or you can operate it in Microsoft Edge. I think those are the two recommended browsers that are published by BHL. There is an identity verification application. You can either use Microsoft Authenticator or Google Authenticator to be able to log into the system. That simply provides a number that you type into the platform to kind of verify that as a second factor of identity verification. That's around there for PHI purposes and making sure that we protect confidentiality. So that application does have to be downloaded. A mobile crisis responder really needs to be on a portable device that is connected to cellular data. So in that demonstration, you saw Casey was listed as, I think, over in Austin, Texas, because he was on a Wi-Fi connection. Right now, the geolocation of the mobile crisis responder is based on cellular data and where you are there. So it needs to be on a cellular device, and you have to allow the ability to be seen in that browser for right now, and GPS should be on available. So there are some enhancements coming where there will be a mobile application. It's currently in development by BHL. I don't know exactly when that'll be released. I've heard after the first of the year. It's definitely not in sync with this rollout, but that might make some of the things like navigation between the tabs that Casey showed there between chat and being able to accept the dispatch a little bit easier when it's in a more native application versus a browser based on a phone or a tablet connected to cellular data. So I want to make sure that you guys saw that. I really do encourage you to look at some of the resources on Virginia Crisis Connect. They walk through some of those nuances, and let us know if you have any questions about it. We'll try to include a few of those things in follow-up videos. Let me see. I also saw some questions about the check-ins. So yes, during the mobile crisis response event, there are check-ins that happen every 15 minutes. That's just what's prompted based on the system and what we're looking at. That continues until a disposition is selected. So that doesn't mean that you can't continue to provide MCR. So that there's a difference between the authorization of 8 hours over a total of 3 days versus the mobile crisis response and selecting a disposition there. So once a disposition is selected, i.e. the individual has stabilized or the individual will move to a higher level of care, that case gets closed and the check-ins will stop at that point. So wanted to make sure folks were aware of that.
So Brandon, can I follow up on that?
Yep.
So please don't just go in and click that everything's been completed until you actually have completed the assessment, because if you hit that SOS button or you need something and you've hit assessment complete, you're not going to get the assistance you need. So remember, this is for your initial dispatch out to a mobile crisis and that initial assessment piece. So like Brandon said, it's not the ongoing level of care or those types of things, but that initial crisis piece, we want to make sure that we can monitor your safety during that whole particular episode until you get a disposition on the initial call. We will not be dispatching you out for your follow-up calls or any of those particular things, just this initial call until the duration of your disposition.
Stacy. I also see a question, and I've answered this a little bit earlier in the chat in a different way. So it was, what if you witness the client in crisis and they call while they're in your presence? Will you automatically be the person dispatched? I'll say yes, generally, with a few caveats. The person has to meet criteria to receive a mobile crisis dispatch. The person that's with them would have to be properly credentialed to respond to that type of a case. So credentials have to match what the need of the individual is. and all of the, things need to be turned on and logged in and all of that. So in general, yes, it's a proximity based dispatch. And so, yes, that should generally happen. I see a question about provider admin account and if they're able to add the second team member or if that can only be done by the dispatcher. I believe that is only able to be done by the dispatcher. So we'll make sure that we have those steps lined out and how you can request that second person be added in. Then we're going down. Let's see, is the dispatcher receiving calls from 911 and then the dispatcher will send it to the responder QMHP. So the dispatcher does not receive calls from 911. There is a whole crisis call center where the calls originate. They either hit directly into that National Suicide Prevention Lifeline or they hit right into our hub. They're answered by trained staff that walk through a risk assessment. And so sometimes that is a call from 911 that gets transferred over, and sometimes it's not. And then once that qualified call taker receives that, walks through it, and decides there's a need for a dispatch, they push a button essentially in the system that says, I want to request a dispatch for this client. And our dispatchers are the ones that identify the people. That way the call taker, as appropriate, can remain on the phone with the individual and continue to provide support and triage and communicate back and forth with the dispatcher around status updates. Our National Suicide Prevention Lifeline providers are not able to actually transfer a call or get off the call once they've initiated that. So that's a kind of a key important piece about why we have that role broken out in our region to allow them to focus on the caller. And then as far as dispatch out, they would dispatch to any qualified mobile crisis responder that would be out there. That's generally going to be a licensed eligible individual that can complete a mobile crisis response and not necessarily a singular QMHP by themselves. I hope that's helpful. And I won't comment on Region 4. Love those guys up there. And we're happy to help out if there's anything that gets confusing. Feel free to drop us a line.
There was one question about if we'll be on the call with the call taker. It depends on which line it comes in. So sometimes if it comes through our National Suicide Prevention Lifeline provider, 988 or NSPL, to kind of go back to that definitions, because we hear that language all around. Sometimes they will stay on the phone with the caller while a mobile team is in transit if the caller so chooses. Sometimes the caller will choose not to stay on because maybe they want to put their dog up or something like that. Because a lot of times if there are pets in the home, we will request that they be secured for your safety. So depending on the situation, sometimes we have someone who remains on the line with the particular who has requested the service. Sometimes there is not. However, if at any time we get additional information, so let's say they hang up and they call back and say, hey, by the way, this is what's changed. You will get that information relayed to you, typically through the chat or a phone call, depending on, again, where you are in process, to make sure that you know something has changed in the status. So, for example, maybe a third person caller has called and now they're saying, oh, well, I found out Demetrios decided to have 4 or 5 cocktails and we didn't know that now, and is showing some signs of intoxication. And they've called back to let us know. We're going to let you know, hey, it appears that maybe someone might be under the influence of some sort of substance when you arrive, so that you can take any sort of necessary steps to monitor that situation or respond accordingly. So we do sort of add those pieces and parts. I will give a shout out to my team. I know sometimes it's hard to present all of this, but we've been doing this for about 2 years. So it's a lot of information to put into this particular presentation. So there's a lot of nuances. So please feel free again to email those kinds of questions to us. We will try to answer them as we go along. When you start doing practice in your database, training with your staff, if a question comes up, just email that question again to us. If there's a lot of it, we might send out another training video. We recognize that this is a lot to take in if you haven't been using the platform. Casey has probably lived and breathed this platform for the last 2 years of his life. So sometimes we take for granted that we know how to use it, and maybe there's some little nuances that you don't know. And just feel free to kind of share those pieces and parts with us. So I think I was trying to see if we answered other questions. There's some
There
questions
was-
about the mobile crisis training. I'm gonna have Tim answer some of those at the end in one big clump, if that's okay. Sorry, Brandon, I didn't mean to cut you off.
There was a couple of questions that came up around, again, just the disposition and like when they sign off and can MCR continue to be provided. So I've dropped that in the chat. So if the individual continues to meet criteria to receive mobile crisis response as a service for that up to 8 hours over a period of 72 hours, the way it's listed in our DMAS policy, just because you close a disposition with the call or with the regional hub doesn't mean that you can't continue to provide that service in accordance with the DMAS policy. So that's just all based on your assessment, the work that's being done. That registration number covers that specific event. So the number you get out of the platform comes with the dispatch, and then you can continue to use that reference number for as long as the individual requires the service and up to that service maximum, essentially. So we're not making any guarantees that they need it for 8 hours or then and all of that. That's up to your clinical staff to determine how the individual needs the service and continue to satisfy those DMAS requirements. I think I said that with in a way that you guys won't hold me accountable for when you have one that doesn't meet criteria. Let's see.
You do
Well,
not,
level one
there was a question about emergency services. You guys do not have to be credentialed to be an emergency services provider. If you need emergency services, though, our dispatchers are more than happy to also help connect you to a emergency services provider of the locality in that you're serving. But it talked about something about how do we know if the person in our team is being dispatched to have insurance. That was another question around insurance providers. If we have an insurance provider, we will certainly share that information, hopefully starting in January, though, that the private insurance will also be required to pay for mobile services. We haven't gotten clear guidance probably on how that's going to look for us to be able to give you an additional information, unless someone else on this call knows a little bit more about that than I do.
Really good question. I just got on a side chat, which was, is this strictly related to DMAS, or will commercial insurance recipients or veterans with TRICARE receive that as well? Kurt, I want to just maybe punt that one over to you because I think you've had more conversations at VBHDS with the commercial payers, but I think we're thinking the same process.
That's our hope and intention and what we're trying to work with. I'll say the private plans are as well. I don't want to say I'm prepared. That's not fair. But the January 1st date for them to reimburse for crisis services is coming as quick for them as it is for you and your billing departments. I think they're still trying to figure out. We're having as much communication with them as we can, or well, let's say it this way. We're having as much communication as we can with the Virginia Association of Health Plans, which represents many of the plans, but not all of them. And they're doing their own ways. But we are advocating that they ensure that the services are indicated and billable the same way DMAS does, so that providers can have the same processes. We don't have the same, they're not state agencies, so we can't compel or cajole them to follow procedures the way we might with the MCOs or DMAS might with the MCOs. But all that to say, TBD, and I know that's tough with January 1st coming very quickly, but we're having as much communication with BAHP as we can to advocate and liaison so that we can have better answers. So short answer is we sure hope so. It's the same. Long answer is we're working on it, and we'll put out information or ask that they put out information as it comes available.
Thanks, Kurt. All right, Casey, you put your hand up, which is awesome when you're emceeing what's going on and you're raising your hand. So one of us will be quiet for a second and let you talk. So what you got?
Shelly's brought up a good question. So the dispatchers may ask if they dispatch you out to a call or a case. And when you're done with the case, they may ask you to put a disposition in chat just so we can log that on our end until we know that it's getting properly recorded and we can find that data the dispatchers do record that data in a place that we know we can get at it. So they may ask for a disposition at the end of the case. So your people should expect to put that in the chat.
VCC is working on collecting some data. We're doing some additional data collection as that is still in progress, so that we can also give you guys back some statistics as well as our other regional and community partners around how this collaboration is going. So you probably will be asked if anything like that. For example, did you have to call law enforcement out as part of your response? That is something that currently isn't captured in the VCC, but we want to know, because a lot of times those are questions we get from a regional hub or from our consumers that we're working with. How many times do you guys call law enforcement out? And it's great to have statistics to say that less than 2% of all calls, which is what it's been for the last, I believe, 2 years, do we ever have to involve law enforcement as part of our mobile crisis response? So that's why when Casey said we may ask you for some additional data, we want to be able to give that back to the folks. And those are things that you can also use when you're working with the individuals you serve. This is also retraining our population to use this as a valuable resource. As we know, a lot of times people have either just, if they're in crisis, they've either run to your office or they run to an emergency room. And we want to make sure that they know that this is an option for them and feel comfortable and safe in using it. So being able to give some of that information back to them is really valuable. Eventually, we hope the VCC will be in a place where it will be able to collect some of that valuable information and we won't have to ask for this duplicate stuff. But in the meantime, we do appreciate your cooperation in advance for helping us help you guys with the marketing and efficiencies of the system. There's been a couple questions around crisis stabilization and referrals to crisis stab. We're not replacing anything that is existing with crisis stabilization right now or the criteria around crisis stab. We're not dispatching folks out to crisis stab. So right now, that system of care hasn't changed. It might in the future, but currently right now, how you have been operating, and Kurt, please correct me if I'm wrong, but how you have been operating is status quo when it results around crisis stabilization. So if you've been getting some direct referrals, getting your own information in, none of that is changing from our perspective or the data platform perspective is my understanding.
That's right. Yeah, that's absolutely right. The only thing that's changing on the 15th is the deployment or dispatch of mobile crisis response teams. So community-based stays as it was. I think as was noted earlier, REACH, CSB Emergency Services stays as it was, all other services stay as they are. This is just mobile crisis response. And I'll add kind of maybe a subtext or part of what I was saying before. There may be some cases that currently are going through mobile crisis response, but could be community-based stay instead in the future, right? If engaging the hub isn't necessarily indicated, or step downs from a hospital emergency department that's currently being done by a mobile crisis response team, maybe in the future could be community-based stay instead. That's obviously a decision by the provider and the person and the other people involved. But the only thing that we're changing here is how mobile crisis response teams are deployed. Nothing around community stay.
There was a couple side questions about the check-in, and I just want to go over that again real quick. Your first initial check-in is going to be by phone. And part of that, again, is we want to listen for some situational awareness kinds of stuff in the background. Is there a lot of screaming or yelling in the background where maybe our dispatchers might have a law enforcement unit on standby or maybe closer to that particular locality? Because remember, we take your safety as the most important part. And we often joke, sometimes our mobile responders get annoyed with our dispatchers because they are super focused on your well-being in the community. So the first one is only by phone. From there on, it is you check in on that data platform where Casey showed in the demo. And again, you're going to get this demo and an updated one to maybe highlight some of these questions a little bit more clearly. You check in. The only time would be another phone call from us is either one, you've requested us to call you, or two, you missed that check-in. And we're going to be outreaching to make sure everything is okay. So we're not going to be calling you every 15 minutes on the phone. you're going to be responsible for checking in on the data platform. And that is something that was set, I believe, as a state wide check-in point. We don't necessarily set that particular standard. So I got a couple side questions about that check-in piece. So the first one will be when you arrive, within 15 minutes, a dispatcher will call you on the phone just to make sure one's okay. We're going to be listening for that situational awareness stuff in the background in case maybe we might want to get additional resources en route if there's a lot of noise or chaos. And then from there on out, if everything's good, you'll be checking in on the platform. If you miss the check-in on the platform, then we will call you. Or if you type in the chat a request for a phone call, we will call you. So those are some things, and that might be a little bit of a regional nuance for some of you who operate in a couple of different regions. Like I said, we kind of do things a little bit differently here than some other regions, but those are some things that we really focus on. And hopefully that answered some of the questions that were put in the chat. And then once you're done and you mark your assessment is complete, this is really important. When you mark your assessment is complete, you essentially go off from that safety check. So please don't mark that as complete until you're essentially ready to go. Because again, that safety piece then no longer is really monitored.
There's another question for Kurt in the chat, and it's really, Kurt, just around, it was mentioned that a hospital can step somebody down into crisis stabilization. And can you give any clarification around that, Kurt, on that process?
I'll give a short version, and then maybe we put it in the FAQs with DMAS, because I think a portion of that answer would come from them. I just know, looking at the DMAS provider manual, one of the referral sources or an MNC is recent hospitalization or engagement or emergency department. Forgive me on the language; it's not my document, but that an ED visit could be a service that leads into community-based aid. So if that's the case, it just stands to reason to me, if someone is at an ED and having community-based aid as a way to get them out of the ED and get them connected to future services and resources, that seems like an appropriate step down. And I think, just again, following it kind of conceptually, if someone's at an ED, the conceptualization of mobile crisis response being that EMT coming to the person wouldn't be indicated, right? They are somewhere safe, but they need to be connected to services that can carry them forward and connect them to what's needed to mitigate the risk and stabilize the crisis. So in terms of process, that's I can't comment on here, but I think that's a good question for the FAQs, and we'll partner with our DMAS colleagues to get a good answer in that.
I answered one question in the chat to follow up to Kurt, when they said nothing's changed, we can still get your own referrals. Again, that is around community crisis STABE. Nothing has changed around community crisis STABE. Mobile crisis response, starting December 15th, has to go through the dispatch function, which is operated by the regional hub. So if it's a mobile crisis response, then yes, that has changed. The request has to come through the dispatch request through the mobile hub. Community STABE at this point has not changed. You know, sometimes that's some nuances, especially for some of you who provide both services. It can maybe be a little bit confusing, but yeah, mobile crisis response, think hub and dispatch. If it's community crisis STABE right now, there's no changes.
Yeah, and I see some more comments just kind of popping up as questions. I think those are better ones to look at DMAS criteria and ask if you've got specific questions about how you can funnel into that. DMAS is probably the right source to help you, navigate exactly what pathways somebody can go through. What we know here today is that we can send you out on an MCR dispatch, and that when we send you on an MCR dispatch, you'll have the registration number that you need to submit to DMAS. to be able to accomplish that billing. But all of the other regs, as Stacy kind of talked about, are the same for community statement. If you have some nuanced questions about that DMAS, there's a DMAS mailbox that's really helpful to get those questions answered around eligibility and things like that to help you as a provider.
The same thing with a few of the questions I've gotten around credentials, QMHP versus license versus some other stuff. Unfortunately, I can't necessarily answer those particular questions as it relates to your billing or how your agency wants to construct your billing metrics or response metrics. So to re-emphasize what Brandon just said, I know a couple of side questions have come to me personally too around those particular parts. Tim, can I ask you to talk about MCR training for a minute and how that looks like and the frequency and requesting of the MCR training?
Yes, ma'am. So the first thing I wanted to start with is I know Brandon mentioned earlier the email going out. We still want to direct all mobile crisis training to the mobile crisis training's email just to keep them separated. So any questions about dispatch or anything else can go to the R5 hub. But anything for mobile crisis training, stick to that email. As far as signing up, all staff that need the training will need to join the wait list. I am copying that link right now and putting it in chat for everyone. So I urge you all, if you have a staff that needs training and they have not joined the wait list, to do so now. As far as frequency of training, we're looking at right now at offering them once per quarter. You all should be on the lookout. A link should be coming out the end of this week for sign up for our sessions that will begin January 8th. They start January 8th, and per usual, we will be offering 2 full sessions of adult, 2 full sessions of youth, as well as the corresponding hybrid class for each of those. I did see a question earlier in the chat about certificates. Certificates is an ongoing issue within the LMS and them not populating. I'm trying to get on top of that and keep it working. If you have emailed me and your certificate is still not available, send me another email and I'll look into it so we can make sure we get those. But most of them, the last time I checked, were populating. It was just an issue of them not showing up on your side, but showing up on mine. But I am in contact with the LMS correspondent about getting that corrected. Anything I may have missed, Stacy?
So as you know, Tim does not operate the LMS. He helps input stuff. So the frustration sometimes around the LMS and the certificates populating is a shared frustration.
Very much so.
To put it nicely, we know that has been an ongoing thing for a lot of you, and I know a lot of you I've taught a lot of you in this room, and I recognize the names in MCR training where it's been a little bit of a challenge sometimes to navigate. So again, let us know. We will help advocate on your behalf to get those certificates, to help make sure you get into the particular trainings. We did up our numbers last year to try to accommodate this deadline. I will say, attendance has sort of been a challenge sometimes. I want to remind you that staff have to attend all the sessions. They have to be on camera. They have to be on a laptop. They cannot take this training on a mobile device. And that is some stuff that's come out from the state level that we have to reinforce. And once you sign up for one of the 6-day trainings, we will offer you the corresponding hybrid to help minimize any sort of confusion around how to sign up, because I think some people signed up for the hybrid thinking that they had signed up for the full course. So we're trying to do some things around making the sign up for the training a little bit easier and a little bit more accommodating. If we get some large numbers, we may increase the class size. But I will be honest, a couple of people mentioned near the end, we were only getting like 14, sometimes 9 people per class, and we had upped the size to 70. So we offered the training with a lot of frequency the first 2 years, and then now we're doing it essentially every 90 days to accommodate new hires and any existing staff. We are trying to keep track of who has taken the MCR training, like Brandon had referenced earlier. You have to have this training along with all of the other pieces of your agency to be considered someone who can appear in the mobile dispatch as someone who has been credentialed properly to receive a dispatch. So Tim does do a lot of those things. So with that said, if you get a staff member that maybe came from another agency or location and they had the training, please send us a copy of their certificate so that we can verify that they were additionally trained. So, you know, some folks are taking it in Region 4 or in Region 3, as many of you operate on mutual borders. So if for some reason you did not take that training with us, please make sure your staff send us a copy of that certificate so that we can make sure that you are credentialed to provide that service in our locality as well. We're also going to send out, as part of our minutes, the link, the email addresses. We're also going to send out the form for to request access to the data platform. Again, I've gotten a couple side questions like, how does my staff get a login? How did they get into that? When you enter into an MOU with us, typically we send that out to you as part of our initial emails. Once we get all the information verified, occasionally that form does get updated, and that crisis continuum email is a place where you can also request an updated form. We do not do the logins. We do not create the logins. You would have to send that to the crisis continuum update to request access in. But we do try, for ease of purpose, send the form to you as part of that initial MOU process. We will resend that out because I've gotten a couple side questions about my staff don't have logins, to everybody, again, to just try to expedite this being as easy as possible for folks to get on the platform.
Just a couple of extra points, you know, Stacy, to the point around certificates populating, there's a previous question about what do we do if Medicaid asks that question, those kinds of things. You know, your email chain is something that I, as a provider, would probably hold on to, that says, I know my staff took and passed the class, and that the hub is working on that. So responses that you would get from Tim around those things, I would hold on to that until you have the certificate in hand and make sure that you've got those things available. I also want to encourage you all that as you have staff that sign up for the training, that you ensure that they attend or send us notification if they're not going to be able to attend and cancel that registration. One of the biggest things that happen is that we open up the class to, you know, number of participants, and we get maybe 50% of the registered individuals actually attending the class, which means that we could have gotten more people in. So please encourage your staff to attend when they're registered for the training, and or to let us know if they're not going to be able to attend, so we can sneak another participant in if we still have somebody on the wait list for that training session. We know it's hard to get new staff in and all of that, but please make sure that they actually show up, attend their training as scheduled, or notify us if not. And you cannot get credit for completion of those courses unless you attend all of the sessions. So it's a pretty regimented training. We didn't invent it. We simply provide it. And so we follow the fidelity rules related to the training and make sure that it gets handled that way. We are nearing the end of our couple of hours together. I wanted to just say, for those of you that were not able to log in to start off with because our Zoom hit a capacity issue, we are going to have this recorded, and we will get it posted back out to our Region 5 website. We will include a link to that and send it out to our participants here. So feel free to share that with your staff, but this recording will be accessible so that you can refer back to it if you need to for any reason. We'll also try to get some of these questions typed up in a format that you can kind of review and follow back to. Again, for licensing and Medicaid regulation questions, I really strongly encourage you to make sure you go straight to the source and ask those questions directly, and make sure you're referring back to those. We'll try to stay in our lane and get you a case dispatched out to be able to serve. And we will be looking at things like data that gets populated here. So we do get to see things like how quickly folks respond, you know, the dispositions on cases, if there are if there's somebody declining a dispatch or things like that. So there's some information that we have access to, and we'll be able to review with you during some of those quarterly meetings that we might host as a hub. So just wanted to make sure that you all were aware of those kind of things. And Staci, Casey, Demetrios, Kurt, any closing thoughts that we need to drop on before we close out?
I'm excited to work with all of you. Like I said, I've worked with some of you and taught some of you in the mobile crisis training stuff and had some sidebar conversations. So I'm excited that we finally are at this point where we get to be more collaborative together. We've been talking about it for a while. I just ask again that you be patient with us as we are learning some things, just like you guys are learning some things, and that we work together and we try to solve problems early on. So if something happens early on or something's confusing, you don't understand, let's try to get ahead of any problems that might arise, so that, as I always tell my staff, I can't fix what I don't know is broke. And behind every complaint, there is a request, so that we can try to work the best we possibly can together, because the whole goal is to serve the people out there in need, and have that passion to help others. So I look forward to that particular interaction. You're on mute, Brandon.
I'd just like to echo what Stacy said, and then just remind everyone that our dispatchers may seem a little pushy at some point, but I promise you, you are their number one concern. Your safety is all they care about, and they want to make sure you get home safe.
So that's the put up with the 15-minute safety checks, because they're doing it because they value your life. And Casey, our dispatchers are all certified as dispatchers, correct?
Most of them are. The ones that haven't been through official training through anyone will be going through one with APCO very soon. So yes.
Have to give a shout out to our team, because Brandon segued it. We are one of the first dispatchers, I think, if not the only one, that is APCO certified, which is a member of APCO, which is historically been known in the 911 center as an accrediting agency and training agency. And we've done a lot of work with them to get dispatch from 988 recognized and have access to ongoing training and support through them as an organization. So when we say that we take your safety and this work very seriously, we've done a lot of the behind the scenes work to make sure our staff gets the training and support that they need, not only from us, but other professional organizations, and the recognition of the work that we do in different spaces. I think sometimes we don't always get recognized for the hard work we do and the risks that sometimes we take in being crisis workers, and having 29 years of crisis work under my belt. I know there are times where I didn't feel like that was always heard. So we do this to say that not only do we want your safety, but we want to be recognized for the work that you do and how valuable it is to the citizens in Virginia.
That said, thank you everybody again for the time. We really appreciate your patience here with us, and let's work toward the common goal of taking care of the folks that need our help. And if we keep that in mind, I have no doubt that we'll be able to take care of all things. All right. So with that said, if I don't chat with you beforehand, have a very happy holiday season. Take care of yourself. Remember, if you don't take care of yourself, can't take care of anybody else. Have a good afternoon.
Thank you.
Thank you.